Hello and welcome to iChom's Virtual Learning Series 2021. We'll give people a couple of minutes to enter the room. Now is a great time to enter into the chat which country and organisation you're joining from. It's always great to see where people are coming from and also see some new and familiar faces. So please do go ahead and enter that information in the screen below. So we'll make a start. I'm Suzanne Gaughan. I'm the President and CEO of iChom, and I'm very pleased to welcome you to today's webinar, Applying Patient-Reported Outcomes for Better Informed Decision-Making and Care Improvement. Since we last met, I'm pleased to share some developments that we've been working on at iChom. In the world of standard sets, we've made a lot of progress in the development of some of the sets. We've brought together a brilliant team of people from across the world for the development of the autism spectrum disorder standard set, and I'm pleased to say that that will soon be published. We've also had a number of the sets published and accepted for publication in academic journals. The Lancet Psychiatry has accepted content for the depression and anxiety in children and younger people. We've also had the congenital heart disease manuscript published in the European Heart Journal, and we've been accepted for publication with psychotic disorders and personality disorders. So we'll make those journals available and links to those once they've been published. With regard to the use of standard sets, we're partnering with PromTime to demonstrate the benefit of using the machine-readable standard sets for cataracts with some hospitals in France. So we're very much looking forward over the coming months to tell you how that project's going and what the outcomes are when we've put the machine-readable standard sets into practice. With regard to the virtual learning series, we're very excited to be able to share shortly the agenda for the November conference. We're expecting that to be live in June. There's still a little bit of time for submission of abstracts. So if you do have a project that you'd like to share at the November event, the closing date is the 30th of May. So all details are on the website, but if you'd like to submit an abstract, that would be greatly received. We'd like to thank our sponsor for supporting the conference series, Edwards Life Sciences. At the end of the conference, at the end of today's webinar, we'll ask you to complete a survey so that you can provide feedback on how today has gone and also provide suggestions for upcoming events. So with regard to today, I'm going to give you a little bit of technical information that the conference team have asked me to share with you in order to help you get the most out of our session. So there should be a slide up in front of you now that shows what kind of view you should turn your Zoom screen onto. So you're looking at the top right hand corner to select either the side-by-side gallery speaker view or the standard view so that you can see both the presentation materials and the speaker. As always, we're keen for this to be as interactive as possible. You can select the raise hand button at the bottom of the screen and put a virtual hand up, and that will allow the moderator to unmute you and you'll be able to ask your questions to the speakers. Alternatively, there's a Q&A function at the bottom, so you can pop any questions in at any point. All of the questions will be answered at the end of the session. We'll also be running a number of polls throughout the presentations today, and we would of course encourage you to participate in those. We're also very pleased to be announcing the Value-Based Healthcare Prize after the Q&A, so we'll look forward to sharing that with you at the end of Q&A, and then there'll be a separate link that we'll share with you so that we can go into the virtual drinks, the networking at the end of our session today. So instructions will follow a little bit later on that. So without further ado, I'd like to introduce you to our workshop moderator, Professor Philip Conahan, Professor of Musculoskeletal Medicine at the University of Leeds in the United Kingdom. Professor, over to you.
Thanks very much, Suzanne. Well, welcome everybody. And it's about a topic that for many of you and me is dear to our hearts, and that is measuring outcome, but in a real world setting. And it's something that's difficult to do. And I'm a rheumatologist, I'm an academic, but I still do clinics for the NHS. and all of us have our challenges in understanding patients' outcomes. So we've got a wonderful array of speakers today from a number of different domains to bring some areas under the spotlight for this topic. So I'd like to start off with a couple of demographic questions, if I may. So let's just run the polling question 1, and let's see who we've got here today. So there's polling question 1. If you'd like to answer that and get used to answering questions. Okay, we've got a good mixture of people now. Okay, I'm just looking down. Other healthcare practitioners. I might get somebody to put in the chat what other range of jobs we've got on board. I suspect we might have some nurse practitioners, but let's see what else we've got. Right, Stuart, can I have question 2, please? And this question is very much relates to, I think, how we can use outcome measurement in practice. It's a quick question, this one. You will know the answer quickly to that one. And then the reason for the third question will become clear when you see the question, but it sort of underpins, I wanted to ask a question before you heard the speakers today about your practice and what you do currently in terms of patient-reported outcome measures. Okay, so we've got 3/4 of people are in a public system. Okay, I think we can go to the third question then, please, Stuart. Now, there's a number of reasons why we do and don't use patient-reported outcome measures in daily practice. So here I've just tried to get a feeling about what you do in your practice at present, given that we've got well over half the people are clinicians of one sort or another. Okay. And we've got, and I understand my question may not have been totally differentiating between option 4 and 5, but this is interesting, and I think we will come back to this later. Okay, I think this is a good way to start our meeting today. So I'll hand over to the first of the speakers, and I'll ask each speaker to introduce themselves. And the first speaker is Professor Ola Rolfsson. And Ola, over to you.
Thank you very much. My name is Ola Rolfsson. I'm Professor of Orthopedics at the University of Gothenburg, and I'm also clinically active, mainly in joint replacement at Sahlgrenska University Hospital in Gothenburg, Sweden. Thank you very much for the invitation to attend this webinar. As a background, I have been involved in the development of the hip and knee osteoarthritis standard set with ITROM. Let's see here. So I will provide an example today from the Swedish Arthroplasty Register about how we use patient-reported outcomes and take a look at trends over time and how they have changed from the beginning of when we started to collect patient-reported outcomes. So these improvement trends, which we have looked a little bit closer to, for that you could give the background that the revision rates, mortality, and other adverse events following total hip replacement has very much improved over the last decades. We have more and more focused on early mobilization, which has yielded a shorter length of stay and an improved perioperative management. And all this goes under the enhanced recovery after surgery. And also in many countries, value-based healthcare has emerged as a leading phenomenon in these multiple healthcare systems. In the Swedish Arthroplasty Register, which is actually a merge of the two oldest national quality registers in Sweden, which is the Swedish Hip Arthroplasty Register and the Swedish Knee Arthroplasty Register. We initiated a PROMS program in 2002. It took some years before it became nationwide. So in 2008, all hospitals performing total hip replacements were reporting patient-reported outcome measures to the quality register. And it's a short set of questions which includes the EQ5D, which is a health-related quality of life questionnaire. We also have a visual analog scale on hip pain, and at the follow-ups we include one item addressing satisfaction with the outcome of the hip replacement. These questions are part of the item hip and knee osteoarthritis standard set, but the total questionnaire and what we're collecting from the patients is not as extensive as the osteoarthritis standard set. We have had, I would say, a great success with this this program. About 80 to 90% of the patients respond to the questionnaire, and just imagine that this is actually a nationwide collection of patient-reported outcomes that do work. So this investigation is to look for changes over time in patient-reported outcomes following a total hip replacement in Sweden, because we wanted to know, are we getting better? What is happening with patient-reported outcomes? Are all these initiatives that are taken, or the new care processes that are being adopted, do they actually help improving patient-reported outcomes? So we looked at the study cohort here, all elective total hip replacements that were undertaken in 2008 to 2015. And we used the data from the preoperative questionnaire and the 1 year postoperative questionnaire. And there were, during this period of time, 78,000 complete entries of data. And to investigate the trends, we used multiple linear and logistic regression analysis, and we divided it into 4 periods. So it's the first period was 2008 and 2009, and then 2010, 11, 12, 13, and 14, 15. So all these 4 time periods were compared. As you can see here, on this busy slide, the cohort didn't change very much over time in regard of sex and age or comorbidity as measured with the ASA classification, the BMI, or the distribution of different diagnostic indications for the hip replacement. What we could see when we looked on the trends, and here we see each year separately, was that the pain at the post-operative measurement, the 1 year post-operative measurement, got lower for almost each year, and there was a very positive trend that patients on average reported less pain at the 1 year follow-up. And similarly for the satisfaction, and just to understand this scale, is that 100 is an unsatisfied patient and 0 is a satisfied patient, or very satisfied with the result of the total hip replacement. So as you can see, the patients on average reported better satisfaction over time. So there were positive trends for all pros. And when we looked at the odds for improving in health-related quality of life as measured with EQ5D, there was a 7% higher, the odds for improvement was 7% higher during 2014 and 15 compared to the beginning of the study period. And when we did these multiple linear regression analysis on hip pain and satisfaction with the result of the surgery, we could see that the coefficients, like the effect of the year of surgery, was positive. The longer there was a positive trend in all these estimates. So we could see significant trend of improvement in patient-reported outcome for hip replacement in Sweden, which we are very happy to see. And we believe that decisions about how to best deliver healthcare should be based on what adds value to the patient. And all these initiatives taken during the last 10 years in hip replacement surgery seem to have had an effect on the patient-reported outcomes. Even though the improvements are quite small, we should remember that this is on a nationwide level that we can see these improvements. And we believe that Sweden's tradition of quality registers has been proposed to be an effective path to stimulate clinical improvement work and to implement best clinical practice and to adhere to evidence-based methods. Thank you very much.
Well, thank you very much for opening the session today. I might ask the audience if there is any burning questions. I have a few burning questions, but I'll perhaps just start with an easy one that says, was this mandated? Do people have to join this PROMS? Do all surgeons have to be involved? What's the level of compulsion to be part of the program?
Thanks. That's a very good question, and there's nothing mandatory for hospitals in Sweden to report to the registry. It's not mandatory to ask patients to take part of this PROMS program, but these quality registers, the clinicians in Sweden thinks that that they get so much information back from the register about the quality and ideas on how to improve healthcare. So the hospitals really want to participate in the register, and they want to be part of the PROMS program.
We in the UK always regard Sweden as the home of registries, since you have a single identifier that makes life really cool for doing data collection. So we're all jealous of that. Right, we'll come back to discussion on various elements of what you've said. Let's go to the next speaker now, Professor Jean-Yves Register. Now, please, and don't forget to introduce yourself at the start, Jean-Yves.
Hello, everybody. My name is Jean-Yves Register. I'm here as a hybrid character. Actually, I'm representing tonight the voice of the patients having osteoarthritis at almost every single joint from the pelvis to the toes, but I'm also a physician, and I'm the current director of the World Health Organization Collaborating Center for Musculoskeletal Health and Aging. And the reason why I'm here with you today is that I would like to share with you my experience of being an osteoarthritic patient and how it has impacted my physician's approach to patient-reported outcome, and how it completely modified both my researcher's life and the way I'm handling my own patients. I think that this is a secret to nobody, that the three major risk factors for developing osteoarthritis at the hip or at the knee are being overweight, are being obese, or having previous knee or hip injury. And you see that when we sum up those three risk factors, we can roughly explain 50% of the fraction of the lower limb osteoarthritis that we see in the general population. My life as a patient is rather conventional. When I was in college and during my medical school, I elicited a sport squash racket, which is probably not the best friend of the joints, and with the rather successful track record in competition, I had to train 5 or 6 sessions of 2 hours each, which means roughly 10 to 12 hours of training during 15 years. And at the end of the day, that resulted in what we have expected, which means muscle tear, joint sprain, ligaments torn almost everywhere, as I said, between the pelvis and the toes. And so you can immediately tick the first box of the risk for osteoarthritis. Knee and hip injury, that's the first one. And that came the graduation. And the graduation, as you can imagine, means as a doctor, mean goodbye to competition, stop the training session, a 15-hour shift, concentrate on during your weekends to the preparation of your PhD thesis. And that means that the sport is gone. And when we as a physician see that type of individual, we always tell them, well, that's important that you never put on weight. So have a healthy diet, have a good lifestyle, maybe choose a little lower impact sport and physical activity. But when you have finished your 15-hour shift, when you have finished to work during the weekend to prepare your PhD thesis, you just want to have a good drink and a good meal. Hopefully I was not a smoker. And all this ended up in such a way that between that sports guy in 82 when I graduated to the professor of medicine I became a couple of years later, I got 128 gram per month, regular increase in weight, which brought me from 72 kilo to 112. And so I tick the second box, the box of overweight obesity. Regarding the sport activity, I eventually remained on the pitch, as you can see, but as the president of a ladies football team, we won our Premier Leagues on several occasions. We went to the Champions League on several occasions, but I should say that it was indeed a very low impact activity, low impact on my metabolism, low impact on my joint, but all this together made that I decreased my physical activity. I didn't have a healthy life, and I got almost 40 kilos, 100 pounds gain in 25 years. And what happened there is that as for many patients, I realized that my hips and my knees were more and more painful. That the activities of daily living, which is probably one of the most important patient-reported outcomes, were endangered, and all of them bedding, showering, toileting, eating, swallowing, personal hygiene, sexual activity, everything was progressively reduced and make me extremely unhappy and decrease my quality of life. At the same time, I was a patient for sure, but I was also a physician, which means that my compliance to any medication was incredibly poor. And all this together, the two boxes having been ticked, overweight and previous injuries, poor compliance to medications, poor life, very, very unhealthy life, resulted in a grade 4 bilateral osteoarthritis and a subsequent bilateral total joint replacement. And that was the most beautiful day in my life. I've never been so happy than after my total joint replacement. And how that impacted my life as a physician and as a patient is that during the last 20 years, I've been working in evidence medicines, recommending algorithms, guidelines for the management of osteoarthritis. And most of these evidence-based guidelines say, okay, you need to go for non-pharmacological and pharmacological therapies. There is a step one where you take that particular medication. If you're still symptomatic after that stage one, go for step two, advanced pharmacological, and so and so and so. And eventually it says, well, if nothing works, and if your hip or your knee is still symptomatic, then consider surgery. And I realized by being a patient, having been so happy that those total joint replacement really changed my life and made my day. I realized that what has been driving me to go for surgery is not that I followed every single step of the algorithm that I myself produce, but the fact was that I have the chance, the privilege to have a partner in life who is 20 years younger than me. And at the time of my osteoarthritis, I had a young teenager boy who wanted to swim, wanted to play tennis, who wanted to run with his dad. And that was really my personal patient-reported outcome. That was that my life was miserable because of my osteoarthritis that drove me to go for surgery. And since that time, it has completely changed my way of approaching research in osteoarthritis. And this is reflected in a recent paper that I published with Philip Konagan, our chairman today, where we concentrated on patient preferences in the management of OA. And that's very simple. What do people want? They want to have large improvement in pain. They want to have large improvement in walking, and they want to be able to cope with all their domestic activities. I've realized that patient-reported outcomes are extremely important, but that there is a significant difference on the way patients or physicians approach the outcomes. And it is critical importance to really concentrate on what matters for the patients. And we did that. We've just heard about the Swedish registry, but we have been concentrating on the outcomes of total joint replacement up to 5 years after surgery in terms of patient-reported outcome, pain, functional quality of life, health utilities. We looked here also at the clinical outcomes after knee and hip joint arthroplasty, and something that we should never forget when we're discussing about the patient-reported outcome, and here is the patient who is speaking, not the physician, is the expectations of the patient before a surgery. And we eventually organized a meeting with the World Health Organization and with the European Medicines Agency to discuss the patient-central health research. And our conclusion was that the perspective of patients is pivotal in health research, in treatment guidelines, and in the authorization of medicine. And that being successful in capturing patient perspectives requires multiple forms of engagement, and also that a continuous monitoring and measuring of interaction is vital to better understand what the patient wants and to get an appropriate feedback to what we are doing. And I will conclude by saying that an important patient-reported outcome is satisfaction. That might be the most important. But to improve and to optimize the satisfaction of the patient, we as physicians need to talk to the patient before surgery. We need to clearly define the expectations, make sure that they are feasible and that they're reasonable. And if we do that, eventually we can make the patient happy. Even they realize that they will never be able to run a marathon, they might be very happy by being able, with 2 prostheses, with all those tears, strained and torn, they could be very happy in being able to run a 10-kilometer walking with an average time, and their satisfaction there will be in accordance with their expectations. So thank you very much for your attention.
Jean-Yves, thank you very much. And unfortunately, your life story mirrors much of the Western world and increasingly the non-Western world. And especially the kilogram per year syndrome. And I have followed in your footsteps very faithfully, both with the sporting and the rest. Now, Ola's happy because of your, we've had a lot about hips doing well in pathways and this. Now, there is a question, I believe, for Jean-Yves, maybe from the audience. Stuart, can we go to that question?
So meanwhile, Philippe, do you want me to answer the questions which are in the chat box?
I like the one, there's one in the box now that I like that's very related, and this was from Wendy. To what extent does the patient's preference outweigh the clinician's view? And this particular topic is around surgery. So I guess this is taking into account patient opinion.
Yeah, it is an important question, because as I mentioned, when you're a scientist, you're tempted to, and you need to go through evidence-based medicine guidelines, and when you try to produce recommendation, clearly you look at evidence-based. But I think that the patient-reported outcomes now are more and more mature, and they need to be more and more incorporated in the guidelines. I mean, the algorithm that we as a society publish with step 1, step 2, step 3, and then coming to surgery is probably something that is dedicated to the average patient and the average physician. And I would say that this has to be translated in the real world. It's not a diktat. It's not something that works for everybody at any single time. And I think that it's more and more important today that we have the opportunity of approaching very accurately the patient preferences, the patient outcome, that really need to talk, have a constructive discussion. For some patients, maybe it's better to start with a couple of pharmacological approach, but some other patients are already at a very late stage of the disease, and or you know that their compliance will be horrible to any type of medications, or they have expectations that will not be met by the pharmacological and non-pharmacological approach. And maybe for those patients, you might just be willing to skip 1 or 2 stages of 2 steps of the algorithm. So it's more and more important, I think, to talk to the patients, to exchange with them, and to incorporate their preferences and their own outcomes into our decision process. That's how I would see that.
Okay, thank you. I'm going to hold questions there and move the rest of the chat questions to the end of our session so we can move on with our next speaker. Please do keep putting in your questions. Some of you have raised very big issues and we're going to come back to them. Now, and Marcella, you're off the hook. We got your message. Thank you. Now, over to Dr. Patricia Franklin, who's our next speaker. Pat, over to you.
Thank you. I really appreciate the opportunity to be with you today. I'm going to open up my slides, and I have included some of my introduction. So let's see here. So my name is Patricia Franklin. I am a physician by training and a health services researcher in the United States. I work at Northwestern University Feinberg School of Medicine in Chicago, Illinois. So it's morning here. I'm happy to be with you today because I want you to understand that I've been thinking about PROs for a very long time. That when I was trained as a physician and a health services researcher, but early on I was leading health system quality measurement in a couple of academic health centers in upstate New York and became the medical director of quality. And I realized quickly that joint replacement and OA, 2 of our most common diagnoses, had no actually very relevant measures. I mean, we weren't thinking about death, we weren't thinking about adverse events. And I started with PROs in the early 2000s, about 20 years ago, testing using the data for our quality measurement. That led me to take a career shift, and I spent the last 15 years leading musculoskeletal outcomes registry. And I'm going to talk to you about 2 of those initiatives. And one is leading a United States national research registry to generate PRO outcomes and norms for our clinical practices and research. And today I sit at Northwestern, which is the home of the PROMIS system. I'm not developing new measures. I'm actually working with the PRO developers on implementation for both quality and clinical care here in the United States and the world, across the world. So my perspective and my overall lessons learned have been that in order to integrate patient-reported outcome measures into total joint replacement practice, these have to be meaningful. And starting with arthritis, OA particularly, and joint replacement made a lot of sense. It's high volume, it's high cost to health systems, and pain, progressive pain, and disability, decline in your physical function are the primary symptoms. The X-ray may measure the biologic metrics, but that doesn't tell us how problematic that the disease is to your life. But using PROs means that we have to be very cognizant that we're including at least, I think, 4 stakeholders, four participants. First, these have to be very easy to complete from the patient's perspective if we want the patient's voice. Primarily, the goal here is to capture the patient's voice. From the clinician's perspective, I think of these data as telling me how the symptoms affect this patient's lives between the visit. I could ask how you are today, but I really want to get a sense of how your day-to-day life is being impacted. So PROs give me that snapshot of the between visit symptoms. The office staff are part of this process. So whether it's registry staff or office staff, it must be efficient and flexibly integrated into care. And last, the more these data can be aggregated and used in quality, as we saw from the Swedish registry example at the first presentation, the better, collecting the data once and using it in multiple ways. And, the clinicians are trained, we are trained to look at x-rays and do a physical exam, and that is our role. But this really helps complement the history, I think, that the PRO is integrated into the visit with these clinical measures. So when there was an opportunity in 2010 to apply to lead the single registry for the US that would be dedicated as a research registry that would use primary outcome being patient-reported pain and function, we would also collect adverse events in that period, as well as annual revision rates. I was eager to jump in and put together a national network of surgeons that we call a research registry in cohort that I want to tell you about. And it's the acronym is FORCE-TJR. It stands for Function and Outcomes Research for Comparative Effectiveness in Total Joint Replacement. For context, at that time, the US was initiating an effort to grow a voluntary specialty society registry with a focus on revision rates, and that continues to expand. But this cohort also has survived the last 10 years and is really generating, I think, important information for the use of the data in the quality spectrum, and we'll talk about that later. So what we did was we obtained a stratified random sample of all surgeons who billed Medicare, which is our single payer system for patients over 65, and called those surgeons and said, we had the funds to collect the data for their longitudinal outcome. However, they had to allow us to consent their patients. So we needed to know everyone going to the OR. We called and consented by phone. And we enrolled those patients and followed the patients, but we offered to send the data back to the surgeons. And surgeons were remarkably collaborative when they saw that they would get data back on their own practice. 75% of the surgeons are community-based. This is not an academic practice network, and very diverse settings. And our goal was to establish national norms to describe the patients in the US who are receiving total knee and total hip surgery, and all ages, because our single payer system is only for patients over 65, and almost half of the patients in the US who receive total knee or hip replacement are under 65. So we needed data on those patients. This is a high-level summary of the process of capture. So once we knew the patient had scheduled surgery, our virtual team clicked into the action, called the patient, got verbal consent, and then we dispensed an electronic survey where patients completed a PRO and their clinical risk factors. So we understood their height and weight. We had their BMI. We understood what other clinical conditions they were dealing with. And importantly, we asked, do you have arthritis in your low back symptoms? And we used the OSWES questions for that. And in both knees, in both hips, because we knew from the beginning that multiple joint involvement was the norm in OA. We then collected OR implant data that we downloaded that in batch from the hospitals, which was pretty automated procedure. We followed patients at 90 days in a year and then annually. And that is ongoing today. We're at 5 years. We're completing the 5-year data collection. We asked patients about adverse events, returns to the OR, of the hospital because of their knee or hip. And we verified that data for anyone over 65. We matched the data with the Medicare claims. So we knew for sure that they had a revision or hospitalization. For those under 65, because this was a research cohort, we verified it with the clinician's records because they knew these patients were enrolled. And what's important here is that we ended up with a very robust data set of risk factors as well as outcomes. And we collect these data annually. And that's why I was happy to serve as the chair of the ICHOM Measure Set initiative for OA and total joint replacement. And we used this template. Actually, it informed a lot of what ICHOM adopted. Overlaps with this measure set for their recommendations. Now, one of the issues I told you was efficiency and effectiveness in clinic. And we did use the 42-item KOOS when we were identifying a well-established pain and function measure, but we no longer do. I led work with the psychometricians to develop a 12-item version of the KOOS and WHOOS that effectively estimates the subscores of the pain and function and quality of life. And that gives us the key data with 4 questions each. And that's our norm today. We also have this crosswalked to promise measures so that we can use global measures as well. And we can estimate the JR, which is a 1-item summary number, but doesn't include these summary scores. So we took that to heart, and now our norm is a very brief 12 items for the hip or knee, plus a subset of the promise measures for ascertaining pain and function each year. Now, how did we use that data? We asked our surgeon network, and they said, first, I want to know, how do my patients compare, even before outcomes? What are their risk factors? And we began to really return, this is a screenshot of a web-based system. The surgeon can log on, and he or she can see the profile. In gray are the force norms, but here's the distribution of my patients with moderate or severe pain. We repeated the pain question from the KOOS for their other knee, and you can see I have a number of people with bilateral pain. So my function is not going to be the same as somebody who had single joint disease at the time of surgery. People with coexisting moderate to low back pain on the Oswestry question, emotional health and well-being. At this point, we were using the MCS at the pre-op measure, which is a subset of the SF12, and BMI, which is a significant issue because obesity in the United States is a real concern, as it is across the world, but our average BMI for a primary hip, for example, is 30 to 31, and it's 27 in Sweden. So it is a different profile. So we use the data. I just want to close that and say we use these data in our risk adjustment models when we're interpreting outcome PROs. But we also found that this was very important, that we worked with Medicare and said, PROs, the degree of pain, especially in the comorbid conditions, is not captured in your risk adjustment model when you're talking about 30-day readmissions. That we know, the 30-day readmission model that Medicare evaluated and published surgeon data, it has a C statistic of 0.65, meaning they're not accounting for the majority of the variation in the model of understanding readmission. But when we added, did the patient also have moderate or severe pain in their knee, their hip, their low back, which isn't an ICD-9 code, and did we ask about their smoking status? These are some of the key significant measures. We were able to improve these prediction models very significantly for both knees and hips, so that I would make a case that risk adjustment, including PROs or patient disease burden in arthritis, is critical in interpreting all outcomes of surgery. And then finally, this is what people expected of us, that we would return risk-adjusted outcomes at a year and say, here were your profile of risk factors, your profile of pre-op pros, and here you were enjoy or use heavily in our system is that we have scatter plots, and you can see who are the people with the lingering postoperative pain or function, and drill down and measure those patients and understand their risk profile, or call them and have them come back to clinic. So making that outcome data useful in the clinic as well as for quality is critical in my experience. So in summary, I wanted you to understand that monitoring population outcomes to report to regulatory agencies, payers, et cetera, I believe requires complete engagement of the patient to collect, in this case for joint replacement, the PRO before data and after data. The timing and response rate matters. 80% of our patients completed their post-op data so that we could establish these national norms that the US needed. And that we do collect complete comorbid conditions and have the patient help us if it's not in the chart. They can tell you their going through the review of systems, their symptoms. Now, this leads to, if this is becoming normative in the United States to collect PROs in clinic for arthritis and joint replacement, and Medicare actually has a rule out for comment right now to require PROs in the periop period for joint replacement. We're working on strategies to teach systems. How can you adopt some of the lessons we learned, very process measures, lessons we learned in collecting PROs? So this paper has just been accepted, but we're putting up a website that we'll be able to have, choosing the right measure, make it relevant to your patients and clinicians. Make sure you understand how to automate as much as you can, what we can push out the requests for people to complete their PROs and send them reminders and link it to their doctor, because they do it for the doctor, not actually, and for their own care, not for me as a registry lead. How do we work with the office staff so they can articulate the importance and engage patients at the visit? How do we interpret the data, both in clinic and for quality? So that's the work that I'm doing now on implementation. But I'm also leading another research study that I want to close with and make sure you understand. And I was thrilled to hear Jean-Yves' request. With PCORI funding, which is one of the federal funders in the US, we have enrolled, we have 36 surgeons in 12 states using a real-time system in the clinic where they report the same PROs and risk factors I showed you, but get a real-time report. And this is a screenshot of that report. And right now, over 12,000 patients have completed these at visits. So this is not limited to joint replacement. These are OA patients who are considering joint replacement and have their first appointment with a surgeon. And we show them today, your score for your new pain COOS was here, or your function was here at 4450. But in our FORCE database, with your risk profile, what we're seeing is on the typical patient with this risk profile has this kind of change. And would you expect higher scores? And that was nice. And they thought that was statistically very interesting. And they used this with their surgeon to say, but we list your risk factors. And you can understand that if you were less overweight, or your diabetes was under control, or you're not smoking, that there are different movement in these calculators and the outcomes. Secondly, and importantly, patients said, I don't just want to know my scores better. They said, I want to know, am I going to be pain-free at rest? Am I going to have pain when walking and with stairs? So in this healthy patient that I've put up here, you can see that over 90% of patients had no pain at rest with that profile, but some did. And 82% had no pain with walking, but some did. And 72% had pain with stairs or resilient. So we're beginning to engage patients in a conversation about expectations, about what they may achieve or may not achieve. Now, this is an experiment. This is research. This is not prime time. This is what I do as a researcher, is testing novel ways to use PROs. And I've translated the risk data in the FORCE registry into these reports. We are enrolling about 1,000 more patients, and then the research begins of evaluating how patients use the data, did it improve their decision quality, and how is it affecting the patient's selection for surgery. So my last slide in conclusion is just to say that Medicare and other payers in the United States are asking for PROs for quality incentives in aggregate. And so we believe that these are here to stay and are an important part of the care of arthritis and joint replacement and in other conditions. And that international implant reviews need these data, particularly to understand revision rates as well as pain and function. And I would point out that the major revision failure in the last decade, pain preceded the problems with the metal on metal hip replacement. So if we'd been monitoring pros, we would have seen this. And we want to collect these PROs in the clinic through the EHRs and optimize the use. But that means that we need to make them highly relevant to patients. And that's where I say that these data are really giving us a snapshot of the between visit experience of the condition that the patients are reporting, and sharing the data with patients, which is what that experiment is that I showed you, is ongoing research that we're conducting today. So thank you for your time and attention, and I will stop sharing there and would welcome questions.
Pat, thank you very much. It's hard when I keep listening for the audience applause in the background here and it's not coming through. Now, I'm going to put the same question that I put to Ola and then follow it up with one from the audience. Firstly, what was the incentive? What was the reason why surgeons came into force?
Yeah.
PJ, why did they do it?
That's a critical question. This was not, so we got the random sample of surgeons who billed Medicare. We stratified them by region of the country, and you had to be invited because my goal was to have an approximation of representativeness as close as we could get. And it was by surgeon membership. Of the first 220 on the list, we enrolled almost 200. And then we actually added some in urban New York City and the Bronx. We wanted some diversity, and in urban areas in Texas for diversity in race and ethnicity. So the cohort is not everyone, but it wasn't voluntary.
What was in it?
What's in it for them?
Yeah.
I think that number one, they knew the PROs were going to be the future in the regulatory environment. Number two, they were very interested in having their own data. And we said the deal with participating is your data are your own. We return your data, the raw data, if you want to use it, not the cohort, but your sites. And secondly, you get that benchmarking website. They were not paid, and patients were deeper.
Okay, and the converse of that, and Wendy Copeland-Blair's asked this question about retaining patients afterwards.
Yeah.
So one is getting your surgeons in, and then how do you keep your patients in long term? And you've mentioned up to 5 years of follow-up. So how do you do that?
So we've been studying that because we want to know what we could learn in generalizable in practice. Number one, we did have research coordinators who called and consented so that this patient cohort would agree to participate. And we know that about 90% of people, because we had English and Spanish language coordinators, were eligible to participate or agreed to participate. That was important to me, number one. Number two is retention. So we started retention, as my behavioral scientist colleague said, retention begins at the beginning. She led the Women's Health Initiative retention initiatives, and we followed shamelessly and said, we send them newsletters. We send birthday cards in those early years because getting to that 80% mark to set those early benchmarks was critical. As the research dollars waned, what we've done is at least an annual newsletter and multiple contacts. And what we offered these patients were multiple ways to return the data, which was the web survey, a paper survey, and a text message survey. So we have lost people over time now that we're at 5 years, and we could talk about that. But in the clinic environment, that first year was the model that we needed to set those benchmarks for quality, et cetera.
I've got about 1 million questions, but we better move on to our last speaker now. Thank you, Pat. And over to John Grady Benson, who I think is ready to go. Yes, indeed. Thanks, John. Over to you.
Thanks so much. I'll put my slides up in a minute. I just wanted to thank everybody for joining, and it's a real privilege to be here. I would introduce myself as a soldier in the war against arthritis, and I'm on the arthroplasty side. I have nowhere near the experience nationally that Ola Rolfson or Jean-Yves or Pat Franken have, so it's a real privilege to be here. What I'd like to do is just give a perspective on a private practice orthopedic surgeon who's busy in a busy environment, and how we try to use data in general and patient-reported outcomes in particular in our journey towards a better, improved care. So with that introduction, the Bone and Joint Institute at Hartford Healthcare, for which I'm the physician in chief, is the only dedicated musculoskeletal hospital in Connecticut. It has 60 beds. We do about 6,000 cases a year. And I thought this was relevant just in terms of all those in private practice or in the public forum on the webinar. We are affiliated with the University of Connecticut, so we have a strong residency program. The Hartford Hospital campus is about 850 beds. For those of you who are not from the United States, Hartford, Connecticut is about midway between Boston and New York. We have an interesting co-management agreement at the Bone and Joint Institute with Hartford Healthcare, which means that we are contracted to take care of musculoskeletal disease at the institution. If anyone wants any more information about that co-management agreement, because it may have some relevance to our discussion, there is a recent article in the American Academy of Orthopedic Surgery Now article recently, and there's the reference. I'm also in a private practice group, Orthopedic Associates, and so the private practice aspect of this and how we apply to Professor Conan's great question, how do you get surgeons involved? And to Pat's initiatives, how do you get patients engaged and their surgeons engaged in this quality journey is of paramount importance. And I would submit with everybody on the webinar, I hope, and certainly the professors who have already spoken, that PROs, what matters most to patients, are extraordinarily important now, not just for compliance, but really to measure, analyze, and apply to what Jean-Yves talked about, meeting satisfaction and expectations, and to really know that we're in a process of continuous improvement. And what I would argue is that a culture of data transparency is the inherent umbrella under which we all need to live, because in order to have great registry data that Ola talked about, we need to standardize our methodology of care, right? Otherwise, the data that we're collecting is all over the place, things that are endemic and replete in healthcare data, right? Who has it, who owns it, how are we collecting it? Standardized care protocols are super important, and that's where the registries are important. I'll talk about that later. At the same time, it has to be personalized care. So you look at Jean-Yves' story about being a former athlete, what does he want for his life? It has to be a very personal story, and we need to meet those personal expectations in the under the realm of standardized care protocols. So this is how we do it. And this is just one aspect of all the service lines at the Bone and Joint Institute. And so what I'm sharing with you is a very busy slide. I want you to concentrate just on the fact that what happens every single month is that all hip and knee arthroplasty surgeons, which is about 11 of us, 7 of us are the most busy, every month look at, and this is all identified data, surgeon's name goes right here on the list. I de-identified it for today's purposes. And we look at all the usual metrics. How many cases you did, what was the length of stay, what are all the adverse events, how many blood clots, how many infections, how many transfusions, and then we track this over time. And so we sit in the same room, not to blame and shame each other, but to have a coordinated care system that allows us to standardize the protocols that we can be on this journey of always getting better. And so if you look at the last 7 years of the Bone and Joint, a very young institution, we can see how that transforms better outcomes. And so from 2014 to 2021, I have all sorts of metrics. This is just one. So if we look at the infection rates from 2014 in joint replacement alone, we've decreased from 0.92 to 0.05 infections, a dramatic improvement based on all agreeing how we are going to do this better and how we are going to agree as a whole to do it better to improve the outcomes for our patients. And again, this takes a no blame and no shame culture of data transparency where there's conversations and not finger pointing, and there's adjudication of data, trusted data, and data collection tools that will improve things. Now, look at that data construct and add, if you will, patient-reported outcomes. So I'm rather a disciple, not just of Ola, but of Pat Franklin as well. I was on the ICHOM Standard Set Committee. It was a real privilege. I'm not sure how much I contributed in a group of very large brains, but we have been participating in the FORCE TJR study. And we've also recently been participating in Orthopedic Associates of Hartford with the Arthritis for Shared Knowledge project, which Pat Franklin just talked about. So if you look at this, and Jean-Yves or someone else, say Mrs. Jones, comes to my clinic and says, my BMI is 35, I would like to walk a distance, I would like to be able to play tennis, my emotional health is fairly good, and you measure all that, and we then match patient-reported outcomes of people like her. They'll never be identical to her, but they'll be like her, similar to her. So those who had similar scores preoperatively, guess what? We're in the realm of predictive analytics, of being able to have a shared decision-making conversation with that patient that says, based on people reasonably like you, you will likely have, and take this example for a knee replacement, a score of 78 out of 100 on your PRO. You're not going to have a perfect result, probably, but you'll be a lot better than where you are. Isn't that a powerful tool, using PROs in this setting for predictive analytics? So our journey for PROs at the Bone and Joint Institute is rather new. We just started this a year ago. Our journey at Orthopedic Associates of Hartford has been for years, and I can't get into all the nuances of that. But maybe at the breakout session, which I'm really looking forward to, we can talk about some of those logistics. But we're clearly involved in trying to get PROs a part of our data-driven decision-making platforms with surgeons intrinsically involved and patients engaged. How do we do that? There are numerous ways to capture outcomes. We use a third-party vendor called Force Therapeutics. I have no financial relationship with them. This is not an advertisement for Force Therapeutics. It's an example of how Force can be used for PRO collection. To Jean-Yves' point, we want multiple touch points of care through the patient journey, whether that's from starting from the rheumatologist, which Dr. Conahan is proficient at, to prior to surgery to after surgery. There's patient education platforms. There's an app on the phone that I can see every day in terms of what my patients are telling me. And I can answer those questions quickly. For today's purposes, this is also our platform for PRO collection. So the ICHOM standard set can be given to the patients prior to surgery, at 12 weeks, 6 months, and 1 year after. And right now we're at our 1 year thresholds. As an example, there was a question about capturing these outcomes. So about 85 to 90% of our patients are engaged in the Force platform. As you might imagine, elderly patients have some difficulties, but they're definitely surmountable. Of those patients who are involved in Force, we have a 93% capture rate of pre-op PROs. Again, we're just at the 1 year mark now. At 6 months, it drops down to 81%. We want that to be 100%, right? It never will be. Those of you who are engaged in surveys and registries know that it's really difficult to get patients engaged, and I'm open to ideas about how to do that better and better. We think that a patient engagement platform that allows for excellent communication between teams and the patient will improve the ability to capture PROs. It's part of what we expect from our patients, and it's part of what patients expect from us now. Think of that also in the realm of the joint replacement and other registries, what we call the family of registries in the AAOS, and we're involved in all of these. As you might imagine, the AJRR is, after 10 years, while behind Sweden and all of Western Europe. There are now about 2 million procedures that have been submitted to AJRR with, I think, 1,300 institutions and more than around 9,400 surgeons. We're also committed to every single registry and every single service line at Bone and Joint. We will be starting the American Spine Registry. We're a key opinion leader for the Fracture and Trauma Registry. And there's a lot of discussion about how do you collect PROs in trauma patients. We have submitted 13,000 cases to the AJRR. Obviously level 2 data, not level 3, because we're just on our PRO journey starting out. And Pat mentioned this, we have to start complying to CMS. And, the era of medical compliance to guidelines, in my opinion, has to evolve. All right. We need a different era of not complying, but being intrinsically motivated to understand that PROs and data collection and sharing it openly, and transparently can change physician behavior, benchmarking our institution against others, doing international benchmarking, and here's where iChime can be extremely valuable to everybody, will allow all of us to get better. So yes, do we collect PROs to get Blue Distinction Plus accreditation or to be in the part of Institute of Quality for Aetna? Yes, but we also want to do it for our patients. It's our responsibility. With respect to data and capturing data in the private practice world, I think many would agree that the CMS database in the United States is replete with error. And as we know, across countries internationally, knowing which data is to be trusted is problematic. Thank goodness for registries, right? I might say I've done 400 joint replacements and they're all doing well. Thank goodness we have a registry and patient-reported outcomes to actually help me prove that or disprove that, understanding what happens completely, so we can always be on that journey for improvement. So what we're doing at Bone and Joint is creating our own database, a massive relational database. And I won't get into all of that. It clearly has the Force Therapeutics data with PROs. It has EPIC, the electronic medical record, with all of the demographics for every patient. Our REDCap surveys capture patient satisfaction scores frequently during the journey. Press Ganey is the tool we use to look at physician communication, patient experience, likelihood to recommend, and it all goes into a massive data lake. I showed you a simple dashboard before. We're using tools like ClickView, Tableau, and ClearSense to make those dashboards actionable. And guess what? If you add cost to it, then you have a powerful value-based tool, right? What actually happens to patients? Are they satisfied? Did they like their experience? And how much did it cost? Key questions in the value-based journey. So that's my brief discussion from a soldier in the war of arthritis. And I hope that we can have an active and engaged question and answer, especially in the breakout groups later. And again, it's a privilege to share briefly this experience. I could talk about this forever because I'm just really passionate about these things. And again, thanks to all for allowing me to share.
Thanks, John. There probably is a venue for you to keep talking forever, but it's a different online site you'd have to be on, I'm sure. Now, you've answered about your third last slide there, answered my usual, the incentive motivation. There was some financial, but it looks to me like you're involved a lot more than some other orthopedic people I know in the States. In a lot of different programs and developing it. So one specific question for you that came up was about Force TJR and how close their set is to the iChime set. And also, are they analyzing your data? And what do they do? What does this middleman do?
Just to be very clear, Force Therapeutics, unfortunately, it's the same term as Force TJR that Pat Franklin led. So just to be clear, so Force Therapeutics does have their own benchmarking data. For instance, they're collecting VAS scores on pain throughout the patient journey. There are numerous institutions now across the country that are involved with Force Therapeutics. So not only can I benchmark my patient data for knee replacement compared to my peers in my own institution, we can do it institution-wide. So based on that data, for instance, I know that post-operative day 2 for our knee replacement patients, there's typically a spike in pain. I can talk about that to my patients in the hospital. I can get them prepared to have to experience more pain on day 2 on average. And that's just one example of the tools that are provided on the data platform.
I'm going to bring all the speakers in now because there are so many topics here. Firstly, I'd just like to say to the audience, I realize everybody is not in the MSK field, and we may use terms and discuss things that are familiar to the arthritis world. So my apologies for that, but it was our theme remit today. But I hope some of the messages are important. I think I've pulled out about 4 themes that I'd like us to start discussing. And I'm going to start with I think I'm going to come to motivation and incentives. And I also want to talk about interpretation. And what a lot of people fear here is that their data is going to be used to say surgeon X is better than me and surgeon Y and interpretation. And Pat's touched on that a little bit. The multi-site joint pain patient, there's a number of routes to go. So I want to get into interpretation. But let's talk about the first big question that's obvious today from what's being presented is, why is orthopedic surgery here and not rheumatology? Why aren't there 6 rheumatologists presenting data here? Or rather, not even rheumatologists, people who do osteoarthritis management that isn't orthopedic surgery.
Yeah.
Why haven't they got 16 presentations that ICHOM were fighting to get on the screen today? What do you think about that? Why is orthopedic so prominent in this PROMS field? Anybody, please.
I'll go ahead, John Eves. I'm sorry.
I know. Just to say that as I've shown in the part of my presentation which related to my physician's hats and not to my patient hats, there have been a lot of publication in the field of rheumatology and rehabilitation as well. And I think that today most of the regulatory agencies, when we're developing a new chemical entity for the management of osteoarthritis or rheumatoid arthritis, are really keen to see PROMS in the assessment file. So I think that it happened today that we concentrated on the orthopedic approach, but I would certainly not like to have the people believing that in the non-surgical management of musculoskeletal disorders, the PROMS do not play a significant role. And it's true for osteoarthritis, it's true for sarcopenia, it is true for rheumatoid arthritis. Just keep in mind, Philippe, you know that story that happened a couple of years ago when a company that I will not name today came with a new file for a new drug in rheumatoid arthritis, and they were sent off by the regulatory agencies, and they went to patient organization, and the patient organization told them, well, everything you did, we don't care about it. We don't care about having a very small improvement in tenderness of the joint and something like that. We want to have a drug that improves fatigue. And nobody had ever thought about fatigue in the management of rheumatoid arthritis. So that company conducted a study based on what was recommended by this patient organization. They came back to the agency and they got their marketing authorization just like this. So I think in all field of musculoskeletal diseases, PROMS are really becoming prominent, if I can say this way. And it happened today that we concentrate on the surgical part of it.
Let me distinguish clinical trials from clinical practice. So absolutely, there is no way I'm going to get a new drug therapy through for anything without patient-reported outcomes. FDA and EMA have accepted that for years, but I'm talking in clinical practice. And I would argue that what we've done, there's a couple of drivers why orthopedics is up there. One is it's costly. The systems are costly, and people wanted to monitor those systems. I give drugs that are very cheap, and I'm not as important as my orthopedic colleague to the system. And the second thing is they have something that works. We have therapies with very small effect sizes often.
That's absolutely true.
And they can measure a change. I could do tools all day on my patients, and there'd be this much change. So sorry.
Yeah, Philip, I think there are 2 things. I think sadly, the fee-for-service structure in the United States promotes attention, focus, and magnification of what is most costly, with millions of joint replacements being done without a concern enough along the way on quality, number 1. And number 2, to your excellent point, without a good enough concern about the continuum of care across the arthritis journey. So the fee-for-service system has created silos of care, rheumatologists in the office. We don't even know sometimes what has been done there. All right. And then the procedure. So the procedure is the easier thing to measure. And then there's cost related to it. And so I think that's where PROs have been focused. And I hope, you know, for instance, through ICHOM's initiatives, that we start to look at the continuum of care, right? When you start with arthritis, did you have an injection? Can you look at PROs before and after an injection? Can you look at PROs before and after you take Humira or any other disease modifying anti-rheumatic drug? That would be fabulous.
I've spent a lot of time, I used the word care pathway in one of the opening questions, and it may not be a term that people always use, but trying to understand that has taken a lot of my time. And there's 16 different routes for you to come into the hospital with your knee pain. And it's all different routes. Pat, sorry.
No problem. No, I was going to just say that I think that both Jean-Yves and John have addressed why I think PROs are so commonly used in US. But as a non-surgeon, I did say that actually when I had responsibility for measuring outcomes and realized, in cardiac surgery, people care very much about minimizing death rates and complications. And in other inpatient cancer care, completely, longevity mattered. In orthopedics, honestly, the good news is there's a huge effect size and people didn't have those complications. And I said, I want to document what we're doing here. And I learned a lot from the surgeons who were remarkably open to saying, well, our primary outcome is pain relief and functional gain. And to their credit, to me, I think the lens was on joint replacement because of volume and cost, clearly. And it was a natural fit, and there was an absence of, of other measures to begin to understand it. And when I first said in a research study, not to clinicians, they get it, but in a research study, it said, there is variation in the outcome. They said, absolutely not. It's a perfect procedure because it has, on average, a huge effect. But there is variation, and now I think we all understand that. The more we've measured it, and it's really spurs the kind of quality improvement John's talking about, of like, how do we do this better? How do we treat those people who are not at the average gain in their, function or pain relief, and maybe leading to, as you said, better tailoring the pathways. So that's why that was my thought.
I think my favorite example is the orthopedic surgeon who does what I'll call the routine joint replacements versus the tertiary center orthopedic surgeon who sees the incredibly complex hip failures.
Yes.
and has to reimburse them. And you see why the fear of just looking at outcomes without some sort of interpretation applied around is a really dangerous. I think it's not productive for our field. But back to surgeons versus non-surgeons, it's just a bit depressing. You've now also got peer pressure on board because it's becoming more the norm for orthopedic surgeons to be on board.
Yes. I would like to comment as well. I think in joint replacement surgery, we have a very long tradition of outcome research. It's been implant survival for many years, but since we have this system in place in many countries to collect outcome around this very standardized procedure, that's one of the reasons why we see these patient-reported outcome measures in joint replacement as much as we do today. There are no not very many programs that are standardized for patients with osteoarthritis. However, actually in the Nordic countries, there are in each of the Nordic countries initiatives for programs for better management of osteoarthritis patients, often led by physiotherapists, and those programs are now starting to contribute a lot of data on non-surgical treatment of osteoarthritis. So that I think is a very nice development, at least in the Nordic countries now.
The Holy Grail would be joining them up with the orthopods. So we do in fact see some life exposure, because I keep trying to explain to my commissioners that people dip in and out of our system over many, many years. Right. And they might come with their shoulder pain this year, and it'll be their back pain and hip pain in a year's time. That's how humans are. And Pat's already pointed out the median number of painful joints in people over 50 is 4. So we've got to have systems that can cope with multi-joint involvement. Right, let me change tack. Population versus individual patient level data. Now, the tools, and I worry about the tools we use a lot, we'll come back to that, but the tools are all developed to determine between group changes from clinical trials. And that's a bit different when we look at individual using pain scales at individual patient levels. So thoughts about individuals versus group measurement. And there's advantages for both. Ola, I think you've shown the group level, you can get system feedback. And some of the people on the call, some of our listeners today, I know are involved in systems analysis. But we've got to be careful jumping between the two.
I wanted to make one comment about that because, and I'm not a psychometrician, and I work with psychometricians now since I'm sitting in the Promise Center. And I know there's a research agenda to begin to understand, because there's all sorts of reasons to be concerned about longitudinal measures and the within patient confounders of how we measure and interpret. So I think that work has to be done and will be done. But the clinicians, what I think has, in my opinion, what has moved this measurement into practice is illustrated by, we ran a focus group with patients and surgeons to ask them about the regularity of collecting PROs. And the patient said, well, daily, my pain changes daily. And the surgeon said, well, monthly's fine. I just want to see how the trajectory is increasing. And I really wonder about the voice of the patient really driving it to know more about how to interpret that data at the person level or at the individual level, not just in clinic, is because they're saying, if I'm fine, I won't answer it. But if I'm not, I want to understand. And it's multiple times a day how things change. So that voice of the patient, to me, is, I hope, will accelerate what we understand about the psychometrics of repeat use in these individual patient uses, because that, you're absolutely right, was not the initial use case. And I do know good scientists who are working on that because they see that, that this is moving into the individual patient level interpretation.
So if I could just augment that, Pat, I completely agree. And so if you look at optimization theory, and if you have everybody go to the same clinic and have risk stratification tools that are collected for your joint replacement patients, and then you have their patient-reported outcomes, how much it costs, whether they're satisfied, then hopefully you can start to develop optimization tools, like in Pat's Arthritis for Shared Knowledge study, for instance, to give some predictive analytics and improve the shared decision-making that you have, myself with my patient. And that becomes a powerful tool for decision-making. And I think that way is one way to improve the patient experience. The other thing that I think we should discuss, and I'd be interested in the panelists' thoughts about the patient acceptable symptom state, right? The PASS score, right? Which is the smallest amount of change in a PRO that will actually relate to, am I better after my joint replacement? Because the patient doesn't really give a darn, frankly, about what their KOOS score or what their HOOS score is. The surgeon does. We do as a system, but how can you relate to the patient? This is the score we're shooting for, or this is the score that's meaningful, so that they're engaged in the conversation. I think that's the challenge we have with PROs that have their limitations and their advantages.
It's great being chair here, because I can throw in, as somebody who is psychometrically steeped, Pat, in an IRT, I worry about most of the tools that are out there. Yeah. And yet Jean-Yves' talk very strongly shines a spotlight on what I call the best outcome, the most valued activity for a given patient. So for somebody, it's doing one thing. For somebody, it's walking with the kids in the park. For somebody else, it's getting to work each day. But trying to capture that is really interesting. Jean-Yves, that's what.
I may be shocking once again in my life, but I would say what really drove me to the surgery was pain during sexual intercourse. It was not pain at night. It was not pain when walking. It was really something that for me that really impaired my quality of life. And at that point, I say, well, you cannot continue this way. You have something to do. So I agree with you that what really matters is different from one single patient to another one, and we have to take that into account. And I think that's where what Pat says about the prediction of the outcome is very important, because if you can tell a patient, okay, you have 82% to be pain-free at rest, you have 65% chance to be pain-free when climbing stairs. And the patients will find in all those different outcomes what really matters for her or for him. And then that might be driving his or her decision in a way that will be totally different for the neighbor. So I think that's really important to consider, that each and every single patient is different, and that their driving force might be really, really different and discrepant.
And feasibility of measuring outcomes. Ola, it's really noticeable that your registry outcomes were short and quick. I like it. There was only a few things captured. That adds to feasibility. Was that clear in your mind when you were establishing the outcomes?
Yes, that was a very important thing, to keep it very brief. Actually, we increased a little bit since 2017, and we are undertaking a little bit. We're actually adding the WHO's 12 this fall, but that has been important for us not to burden the patients or the clinics with too large questionnaires. We have gotten feedback from patients that the brevity of the questionnaire it's too short, and they want to describe more about their health status than we collect. So we have taken that, and we hope that the response rate will stay high, even though we increase the number of items to respond to.
I think we're coming up. We might be able to get an extra 10 minutes on this group panel discussion before we break out. Okay, I think Anna's just given me a timeline. We've got 7 minutes. I just want to highlight one of my favorite orthopedic surgeon quotes is the surgeon who always uses his tools on his outcome for his patients. And I think he uses the Oxford knee score, which is pretty similar sort of score. And he loves the patient who comes in and says, my pain's terrible, my life's awful, please replace my joint, and scored bad. The patient then comes back 3 months post-operation and says, thank you, thank you, thank you. That was the best thing in my entire life. Thank you, thank you. And he looks and the score is the same score. And of course, I want to highlight to people listening, you've got to be really careful about interpretation. And many of these scores don't say, you know, I had pain on walking to the front door. Right. Now I've got pain on walking to the supermarket to do my shopping. That's it. That's still a 7 out of 10, but it's a whole different life experience. So I'm back to the tools again and what the tools are telling us. And we have to be very careful before employing them. There's a few questions come in that really fall under what I'd call the issue of why can't we get more people involved in outcome measurement? So back to the incentive motivation issue. Now, sometimes there's system imperatives, and we've covered some of those. Many systems want to have some sort of auditability these days. I think that's pretty common across a lot of medicine now is understanding audit, at least for safety. And sometimes we've started things on the back of safety that allowed us to also measure efficacy. Other thoughts on introducing systems? John, you've had to introduce a lot into routine care.
Yeah, I think there's an ethical responsibility to do it, and I would hope that surgeon colleagues would be interested in that aspect of it. And I would hope that policies, for instance, in Johnny's great work of the World Health Organization, not only in the incentives that are given through Center for Medicaid and Medicare Services in the United States, there is clearly financial pressure to do it. You have to prove your quality and understand your cost to be able to be in the competitive fee-for-service marketplace in the United States. So that's a pressure. But I would hope that what individual surgeons and institutions start to do is really be less fearful of the adverse events of the person who didn't do well, and really capture that patient's experience and say why and how can we get it better. And that's a culture. That's creating a culture about that. And I don't have all the answers by far, nor necessarily all the right tools, to your point, Philip, about how we best do that. The patient you just described, I think, is that patient who wanted to do one thing. I want to get in my kayak, and now I can't. I can walk to the store. And so it gets to your point. The PROs do not encapsulate the everything about the patient experience, but they're the best we have as a validated statistical tool, and we have to start somewhere. And hopefully that we'll get better all the time. I don't know if that answered the question or not.
I think that, I know, I agree with you completely that the culture has to evolve to make it a value and a priority. But the second part, I think, and this is my public health hat, is that in an era of chronic conditions, the symptoms between visits, getting people out of their medical mindset, and I say that as somebody who's a clinician, to say, actually, what brings the asthmatic into your office, or what brings the congestive heart failure patient into your office, or the arthritis patient, is a progression of their symptoms. And that's how I think of this. It's like if the OA is getting worse, they need to, patients start to consider, do I need to see my rheumatologist, my primary care doctor, or my surgeon, and ask what options I have. And that so it's not just patient willingness to complete it and being short. To me, if it's relevant to them about describing what their lived experience with their chronic disease, I'm hopeful we'll see broader than orthopedics. Cardiologists and rheumatologists and primary care doctors beginning to see, or geriatricians in general function, declining in physical function. There are these constructs. So that's my public health hat. I don't know that that's what motivates everybody, but I think that, I do think it's why I see it as even more and more relevant in monitoring people over time with these.
But I think cultural change, and it's happening in a whole lot of different systems. So I'm hoping that's broad. Now I have to watch out because I think we're going to be taken to our breakout discussions, or our chance for a drink somewhere discussion now. Stuart, is that right? Are we about to move off to our different groups? And
we're handing over
we
to
ask
Suzanne
to finish up for us.
Yeah, we're handing over to Suzanne.
Okay, Suzanne, over to you. Thanks.
Brilliant. Thank you so much. I enjoyed the discussions so much. And as someone who is having physiotherapy at the moment for a severely fractured talus bone, it's particularly acute for me at the moment. So I really did enjoy it. Thank you so much. So hopefully we're going to have some slides come up on the screen shortly, because we are announcing the winners of the Value-Based Healthcare Prize, I believe. One of my colleagues will shout now if I've got this completely wrong.
Okay.
Drum roll, please. And so we're very pleased to announce the winners. So the overall winner of the 2021 prize is Join VASC, so the Joinville Stroke Registry, for their community stroke program. So huge congratulations. And if we move over to the next slide, we've got a breakdown of all of the other winners in the various areas. So huge congratulations to everybody who's been winning here. Chronic Care Australia for primary care, Happy Health Platform for the Collaboration Award, Cleveland Clinic for the COVID ED to home with enhanced monitoring, and in the Cost Effectiveness Award. The Patient Outcomes Award is to Dell Medical School. Big congratulations to Dell Medical School. We're very pleased to partner with Dell Medical School on a number of initiatives, so that's really wonderful. And big well done to Parkinson's Net for the Inspirational Award, and the Community Award also to Join VASC. So that's really brilliant. I know that it's a big long process, all the applicants, and when we're delighted to work with the organisation to help them help community members take part, and so congratulations to those winners. So that's great. So there may be one other slide before I start to encourage people to move on to the networking, just with the details for the next event. So a huge thank you to our phenomenal speakers today. I'm sure, looking at the comments, everyone has found this as wonderful as I personally did. And so really huge thank you. Thank you to all of the delegates for joining, taking part. I can see lots and lots of questions. I'm sure there are unanswered questions. So please do join the networking session. And the next session is on the 30th of June. And patient-reported outcomes, data management and application in practice world. So specifically looking at heart failure and stroke. So we very much look forward to welcoming everybody to that event on the 30th of June. In the chat now are the details for the networking session. So if you now leave this session, click on the session that's in the chat. The meeting ID and the password is recorded there, so you might want to copy and paste that. Click on it, it will ask you, do you want to leave this meeting? You can safely say yes, and click on that link and you'll go into the next Zoom session, where we will break into groups, and everyone can have their glass of wine ready, beer, or perhaps a cup of tea at this point, depending on where you are in the world. So I'm encouraging everyone to click that link now. Thank you all so much, and I shall look forward to speaking to you all in the breakout very, very shortly. Thank you so much.